Well, yeah, welcome everybody, and thank you for giving up your time today to join our second APPG on cerebral palsy. And can I encourage people today to, if you're going to be tweeting, there's a hashtag APPGONCP. I don't know whether that's going on the screen anywhere or not, maybe, but it's capital O N capital C P. That'd be great. Unfortunately, Paul, who is the other chair, Paul Maynard, has been called away on something urgent, so I'll be chairing today. And I just want to set the scene, if you like, first, before I introduced the first of our really wonderful speakers. We've got a lot to get through today and some really interesting speakers. So just to set the scene, it's, well, currently, as you all probably know, there's a lack of clear nationally implemented pathways of care for infants and children with or at risk of cerebral palsy, which highlights the fragmented state of services across the country. And whilst there are examples of best practice, of which we'll hear about today, there are also too few regional transdisciplinary centres of excellence for caring for children with cerebral palsy, meaning that a postcode lottery determines whether families can access the specialist support that they need. And Action Cerebral Palsy, the charity that established this APPG, has conducted research highlighting the extent of this postcode lottery. And I'll just share with you some of the findings of that. First of all, only 6 NHS trusts and local authorities, of a total of 2,015 contacted in 2018, were able to say how many children with cerebral palsy lived in their local area. The majority of NHS trusts still don't have a formal care pathway for children with cerebral palsy, and many use a catch-all pathway for children with physical disabilities, and care plans often revolve around access to physiotherapy rather than a rounded approach drawing on all therapies. And all infants and young children at risk or with cerebral palsy and their families need to be able to access swift and seamless pathways between local paediatric services and centres of excellence, where transdisciplinary teams or specialists work together on assessing, monitoring, therapy and treatment. And this is, well, it's, as we'll also hear, that it's currently just available to a few families, creating hardship, disruption and distress for many people. So some of those are quite stark statistics there, and I think we all agree that we should be further on than that. But we do have speakers today who'll be talking about the positives. And our first speaker is Bert Martin, who is a young adult himself with cerebral palsy, and he wants to talk to us about his experiences in accessing an effective care pathway. So straight over to you then, Bert.
Thank you very much. So I was part of the last APG as well, and I spoke then, for those of you that were there, of a roadmap to the future. And today I want to talk about the pathway that got me there. So one of the most poignant quotes that comes to my mind almost every time I speak about cerebral palsy is a quote from my mother, which is, "As a family, we were plunged into a world of disability we knew nothing about. And when we found the PACE Centre, we were no longer alone." And so when I was writing this, I was trying to drill down into what is meant by no longer alone. And for me, it ended up meaning 3 things. So firstly, it gave us access to the knowledge and understanding of what CP was, how it would affect my development, and what we could do to mitigate the impact of CP. Importantly, it showed us the roles of the multi-transdisciplinary team around us that we were lucky to have through the PACE Centre, and simple things like we began to understand the terminology used from a very young and early age. And so we weren't frightened by it as a family. And my parents were also able to use that to their own advantage if they weren't particularly impressed with the medical professional they were in front of. So the PACE Centre and the Centre of Excellence really did arm us with the knowledge we needed, and we were put in the driving seat to be able to build my pathway of care. Secondly, we had an understanding of the team and support network that was around us. And I mean, you know, input from speech and language, occupational therapy, physio, and a plethora of equipment, i.e. leg gaiters, standing frames, sleep systems, and the all-important seating. The list really is endless, and I could fill the whole 5 minutes by talking about it. But what was seen to me as a young boy as extravagant torture equipment quickly turned into a really good safety net and some of our best assets. Whether it was my gaiters preventing contractures in my knees, or wearing orthotics to help me manage my foot position to enable me to walk and move safely, we as a family were able to appreciate the long-term goal in order to keep my legs mobile for a candidate for later surgery, which, to be honest, the main important thing there is that it gave us purpose. And thirdly, the most important thing for me is the cohesion of services. As I said earlier, it's difficult to draw down exactly what the power of a centre of excellence really is, you know, because you take it on an individual case-by-case basis. But actually, for me, it was that we had a plan. There was a plan in place, and we were able to appreciate, you know, all of the long-term goals and have the knowledge to seek the best intervention for me with guidance from PACE. Now, I was lucky enough that this came in the form of the Nuffield Orthopaedic Centre, which is, in my opinion, another centre of excellence, and where I had my surgery. The cohesion between the necessary cohesion, between the pathways of care, for me is summed up in the words of my surgeon, which is, I can only do some of the work. 25% of the work needs to have been done to get to this point. 50% of the work is surgical intervention, and the remaining 25% comes from care and rehabilitation post-surgery. Thankfully, for me, the remaining 25% in aftercare couldn't have been handled by a stronger team at the PACE Centre, not to mention, by this point, my purposeful and well-informed family. I've spoken before about early intervention and surgical outcomes in my treatment pathway. But to be honest, I just want to stress that you need to be cohesive and you need to be able to work towards common goals. Whether it was the daily input from PACE or the overarching surgical aspirations from the Nuffield, it was a truly holistic approach where professionals communicate, best practices shared, and outcomes are improved from a position of knowledge. But what does all of this mean for me as I sit here today? It means that I'm able to understand the significance of my past interventions and how beneficial they were, which on a personal level allows you to rationalise your experience as a disabled person and understand and be appropriately grateful to your family, the PACE Centre and the Nuffield. I'm now able to continue to engage with my treatment from a position of knowledge, understanding the landscape of services, and thankfully how to access them. My treatment pathway and the centres of excellence that I've been afforded access to has allowed my family to do the things that all families wish to do to help their child, get them the best care that they can at the time and look to the future. And it really is my hope through engagement of days like today that we're able to bring my reality and relative success story to be the norm, not just an aspirational standard. So thank you very much, and I hope the rest of today is as productive as the last one was.
Great, thank you for that, Bert. And you know, it's so wonderful to hear that you did have that holistic and very individual care plan. And I remember the years of having in my house all of the gaiters, the standing frame, the chair, the splints, everything. You needed an extension. Well, we did get one finally, an extension for all the equipment that you build up. Mm-hmm. So as anybody, I'm gonna, well, I'll go on to the next speaker because we have time for some discussion later on. So I want to go straight over to Lindsay Hardy, who's occupational therapist and director of clinical services at PACE. And Lindsay's going to explain how the voluntary sector can fill the gaps left by local services in many areas in the UK. So over to you, Lindsay.
Thank you very much. Yeah, I was asked to present to you today about the role of charities when working with children with different needs. Sorry, I have now, as this screen has come up, I have lost mine. So I apologise. You're just going to have to give me a moment to find where I was. Thank you. So the House of Lords Select Committee on Charities states that charities are the eyes, ears and conscience of society. They mobilise, they provide, they inspire, they advocate, and they unite. So from the charity perspective, I was going to start with being the eyes and ears and consciousness of society. I'm going to share with you the journey of a family that has recently accessed our early intervention services, and this is just one of many families' stories. Their baby was born at 32 weeks plus 1 day. They spent some time in the neonatal unit, but as the child was over 32 weeks, he was not for the routine follow-up you would expect for a younger, earlier birth. At 6 months corrected, mum was really concerned that he wasn't using his left arm. The health visitor, which was great, picked this up and was able to refer to local physiotherapy services. But at this point, they felt there were no concerns. Anxiety grew for the parents, and a recent MRI scan now shows that unfortunately there is indeed brain damage. Even this, however, has not led to the provision of support for this family. The physiotherapy felt that the concerns were only their upper limb and therefore not their area of knowledge, and they would refer to OT. Occupational therapy will not see children below the age of 2 years. This is quite common. We find this quite commonly, in fact, and I'd also like to mention at this point, this is also often the case for speech and language therapy as well. So this family, like so many others we see, even when there's a known condition, still cannot access services. The family, like many others, trawled the internet and found us, and now as the child turns 11 months, they are getting some support. However, the intervening months will likely have impacted the child's development and have most definitely impacted the parents. The worry and concern they've experienced has built anguish and despair. This mum, like so many, is coming to the end of her maternity leave. It has not been a time of joy and wonder, but of frantic anxiety and now grief as she returns to work and will have yet another challenge to access the recently found support. Early intervention should be about harnessing the power of early in shaping the development of the infant brain and recovering potential, about supporting children and families in the earliest days, weeks and months of life. It should be about the provision of accessible, personalised therapies to support all facets of the child's early development and the family's needs. Being the eyes and ears, what we can tell you is that children are being missed through failure to detect. When detected in many cases, there is a wait and see attitude, or more shockingly, as we heard this week, there is no point attitude. And frequently, anyway, no therapy available until at least 2 years of age. What we can tell you is that we have a system where early intervention for families with children with known or at risk of neurodisability is sparse and really is a postcode lottery. Accessing what we do have is confusing and disjointed for those working within the system, never mind for those who it's supposed to serve. Sadly, as others have said, we've been here before, and it just feels as though we keep putting this challenge into the too difficult pile. In the 2018 Research Policy and Practice for the first 1001 Critical Days publication, Penelope Leach wrote that as a society, for infants at risk, we do not do what we know should be done. Are we, in all consciousness, okay with this? Secondly, then, charities are there to mobilise and provide. Despite the growing knowledge that providing interventions early is physically, emotionally, and socioeconomically essential, early intensive intervention is still scant and too difficult to access. Charities exist for public benefit and to provide assistance to people at times of need. If there wasn't a need, we wouldn't be there. It is for this reason, it's for the reason of need that, like other charities, PACE has sought to escalate its family-focused early intervention service to provide more easily accessible best practice early intervention when it cannot be found or accessed through statutory services. As with other charities, we've been able to step in and be accessed directly by parents without them going through a restrictive referral process, especially during what has been a seriously challenging year. In preparation for this talk, I asked a mum yesterday what the charity had been able to help her with. Her response was, just about everything. We have received no local services. Her child is 14 months old and has spastic quadriplegic cerebral palsy. Charities inspire, advocate, and unite. At PACE, we are more than ever convinced of the importance of early. We want to join the chorus of all of those across all sectors calling for better early detection, the 3 to 4 month health visitor checks, the need for increase in health visitor numbers, the use of the digital red books to facilitate faster detection and enhanced awareness training for all those involved in monitoring our children's development and indicators for CP. We want to join the call for more best practice early intervention services that can be nimble, quickly and easily accessed, family focused and freely available to all high-risk infants and their families. Maya Angelou says, "Do the best you can until you know better. When you know better, do better." We know a lot about what better is. Please let us get on and collectively create a better future for these children, the parents and society. Thank you for listening. And I want to say thank you to Action CP for inspiring, advocating and uniting us in this endeavour.
Thank you. Thanks for that, Lindsay. And it's great to know that you're there doing such brilliant work for people. But again, postcode lottery is shocking. If I may, I'm just going to go straight to the next speaker, and just to remind, we've got a few to get through this afternoon. So just to remind the speakers to stick to their times if possible. I know you all have an awful lot to say, and it's really interesting, but if we want to get through it all, let's stick to our time. So the next speaker is Dr. Jill. Now, I'm not even going to pretend to know how to pronounce this with the W in there. Is it Jill Cadogan?
Cadogan, yeah, just Jill. Jill's fine, it works, that's fine.
Oh, well, right.
Everybody knows me as Jill.
And Jill's a consultant paediatrician at the Evelina Hospital. And I'll just hand straight over to you, Jill.
Great, thank you. Can people see I've just got a few slides if that's helpful. My name's Jill Cadogan. I'm a consultant paediatrician at the Evelina London Children's Hospital, which is the regional South East Thames Centre. I'm here with that hat on, but I'm also here as Honorary Secretary of the British Academy of Childhood Disability, which is a multi-professional organisation for children with all types of disability in the UK. And we started off as a professional interest group, subspecialty group of the Royal College of Paediatrics and Child Health, and became a charity in 2018. This is, I work at the Evelina London Children's Hospital in Westminster, and we cover a massive region across the South Thames and Southeast of England. I feel very privileged to work in that team because I can't flick my slides forward. Why is that not going? because we are actually, as an NHS service, extremely well resourced with clinicians, medical staff and allied health professionals. I think we're probably one of the most privileged NHS providers in the country. And we provide a tertiary level support, and we have some quaternary services for the neurosurgical interventions for cerebral palsy. We have a regional clinical network across the South Thames, but then we work across the Pan Thames region for procedures that might be offered in say, Great Ormond Street that we don't offer here, and vice versa. And we do have a service of neurodisability outreach, training and support in acute neurology, neurodisability and with AHPs. And I think that's one of the real benefits we've got in our region, which I think is in lots of regions in the UK, but we certainly have better provision here, is that our AHP models work very closely with the local AHPs. So, for example, we have been successful in integrating the cerebral palsy integrated pathway for hip surveillance into the Southeast by funding the database through the Evelina charity provisionally, and we now have so that builds a database of children with cerebral palsy with their regular hip surveillance and measurements for with direct referral into the regional orthopaedic centre that can see x-rays. We have, if children have medical interventions and their local teams are not able to provide the follow-up intervention therapy, we've now developed additional support that our therapists from the Evelina can do in a collaborative approach with the local OTs and physios, so that the child has the OT, the local delivery, but with the tertiary guidance. And our neurodevelopmental team, which works within child psychiatry, also do remote and locality-based support with challenging behaviour and feeding interventions. And we're a big team. We have physical, oh, hang on, it's gone forward and I didn't want it to go forward. We have physical neurodisability, but we also have developmental services. We have a sleep team. We have acute neurology teams, and we have neonatal neurology and neuroimaging teams. So we can pick up the babies very early on, and they can be referred into services, and to certainly the OT services through Evelina can work with very young babies also. And we work very closely with the orthopaedic team and the palliative care team, not just in end-of-life settings, but in symptom control management, which is very helpful. And I could add more cogs there with gastroenterology and or neurosurgery, but my space was an issue. So we're very lucky. I was asked, what does good look like when doing this talk? And I think I can much better say now that there's no shortage of evidence, recommendance and guidance of what good should look like. There's been a massive work in the last 5 to 10 years about scoping NICE guidance. We've got the NCPOD review of care. We've got NICE spasticity guidance. We've got the cerebral palsy integrated pathway for hip surveillance. And we've got emerging evidence on what interventions do work. And there's no shortage of will from professionals, parent carers, third sector organisations to get things right. And good would look like seamless communication and transition between neonatal, community paediatrics, acute paediatric teams, between primary, secondary and tertiary care, and between health, education and social care. My next slide, it seems slow to move the slides forward, sorry. But there are challenges, and I think these are going to be highlighted time and time again. There's a significant lack of resource in all settings, but particularly secondary care settings. We've already heard mention of multidisciplinary teams like occupational therapy and speech and language therapy in particular, even more so than physiotherapy, are not funded in several regions of the country for preschool children at the time when actually, if they've been spotted as high risk infants, you have plasticity of the neuroaxis and you can make change. There's been a massive service redesign and natural wastage, I call, of very experienced professionals. So the rocks of the community, the physiotherapists, the speech therapists that are highly experienced, have dealt with hundreds of babies over the years and work in not just their own profession, but have an interdisciplinary knowledge to how to support families. And I think with care redesign, what's happened is we've lost some of those key skills in departments and community departments. And I think there's been a massive drive, and this is speaking with my BACD hat, demand on community paediatricians to other areas of practice, needfully, because there's great need in the other areas, but safeguarding, neurodevelopmental assessment, ASD, ADHD, which means that they've got a reduction of their time to physical and medical complexity, such as children with CP. So then they refer earlier to tertiary teams, and then there's a de-skilling of that population. And I just wanted to quote a colleague who I hope might be on the talk today, and if so, thank you for this article. But she wrote, Hilary Cass wrote an article this year in Developmental Medicine and Child Neurology, and this story is about 4 people named Everybody, Somebody, Anybody and Nobody. There was an important job to be done, and everybody was sure that somebody would do it. Anyone could have done it, but nobody did it. And I think these children sometimes fall through the background. Everyone knows what we should be doing, but actually whose responsibility is it? And the other thing is geographical complexity. So many children are in one postcode, or their health is in one postcode, in one area of funding, and the education is in a different area, or their school's in a different area, or, you know, they live the wrong side of the street, literally. And I didn't really get geographical complexity until I moved down from the north of England to London. And we think of our network in London, and we are very privileged with resource. I can't move my slides on. We are very privileged with resource, but this is from, I think, last year or the year before, the care provider pathways from the southeast of England to the London hospitals. Please don't try and understand it, but I just want to show you how complex the referral pathways are. And it's incredibly challenging for professionals and people to know who they should be referring to when, and who are the right people. So just trying to move on. So how do we get good? If we know what good is, how do we get there? So I think the first thing is making sure that we do the basics right. And there should be a basic level of competence of all professionals in primary and secondary care services. And those professionals should know when to seek help and to be supported by tertiary and specialist network. We have to provide the resource to support all members of the MDT in community settings. It shouldn't be a lottery as to whether people get physio or OT or speech therapy. And we need to use the skills that different professions offer appropriately. So if it's a skill that needs to be offered by one AHP, that should be delivered and not by someone else. And I think we need to have really meaningful integration between health, education and social care. And we need to remove the artificial boundaries that exist at the present time. But there are opportunities. I think 10 years ago, paediatric neurodisability and evidence of intervention and therapies was much more limited than it is now. And we are developing an evidence base, and there's a massive push to continue to do so. We have got guidance on breast practice. We don't need to develop, to rerun the profile of doing another, what do we need to do? And we also have the will. We want to make things better. And I think the final thing I want to say is that this 2020, if it's shown us anything, is that professionals are receptive to change. In less than 6 weeks in March 2020, we completely rejigged all our care pathways, all our ways of working and how we coordinate care. And it absolutely wasn't perfect. It was far from it. But we've shown that as a bunch of professionals and as an organisations, we can suddenly change things. Things that hadn't been done for years because we don't do it that way are now done that way. And I think there's a really, really opportunity for new ways of virtual working and coordinating care. Some of the team around the children's meetings we have now right across the country with multiple professionals involved in a child's life can be done. You can get, we can have our occupational therapists doing school assessments remotely with a teaching assistant that's going to be working with the child, and we can have community paediatricians examining children neurologically in their clinic, and we can be joining in as tertiary specialists, you know, giving advice and giving support. So I think there's opportunity that we can move it forward. So I think that's about all I've got to say. I hope I haven't overrun too much, and just wanted to ask any questions.
Okay, thanks so much for that, Jill. And there will be time for questions at the end. And so I'm going to go straight on to the next speaker, and we are running a bit over time. So again, if we could stick to the 5 minutes or so, that would be great. And it's introducing now Dr. Karen Horridge, who is a disability paediatrician in South Tyne and Sunderland. That's my neck of the woods. So welcome, Karen. Over to you.
Thank you very much. I'm your constituent in Durham as well. So I would like to turn this on its head, if that's okay. I prefer to reframe Centres of Excellence to excellent care everywhere, as only then will all children with cerebral palsies have equal opportunities to achieve the best outcomes, reach their goals and achieve their dreams. I believe that a bottom-up approach is needed, starting where the children are in their local communities. After all, the cerebral palsies are the commonest of all the physically disabling conditions of childhood. Key ingredients are high quality, locally delivered multidisciplinary care that is well led, with clear handing on of the baton of leadership of multidisciplinary care, including on transition to adulthood. All of this needs to be underpinned by robust population data that can evidence equality of access to interventions and outcomes. We now have data capture embedded at the point of care in all our children's clinics in Sunderland, but this isn't the same everywhere, because clinicians in other places don't have those easy to use electronic interfaces to capture the needs of their patients. This must be addressed at all levels, with policy and drivers in place to ensure that electronic medical record systems are fit for purpose for clinicians to use. Families tell us that they value care near to home with the least possible disruption to education and to their lives in general. When I first came to work in Sunderland in 2001, children with cerebral palsies were scattered across a range of clinics. Some were seeing their neonatologists into their 20s. Some were seeing the orthopaedic surgeon or the general paediatrician that was just focusing on their epilepsy, but not considering their wider needs. Some were falling down the cracks in between all of the above. We worked with families, we listened to their experiences, and then we redesigned our services. We now provide one-stop shop clinics where children and young people with cerebral palsies and other children who we think would benefit from this joined up approach come along and see the disability paediatrician, the paediatric orthopaedic surgeon, the orthopaedic nurse specialist, the physiotherapist, the occupational therapist, all together. We take our multidisciplinary clinics out to the special school. The child's day is disrupted as little as possible, and so that we can make those important links with other practitioners who are involved with the child's team. We also deliver them in the physio department, in the children's centre, where there's parking, where there are wheelchair scales, and where there's public transport for families to easily get there. We can then have the right physio for the child to come in for their appointment. Our clinics are really well attended. The families like them. We start off in the waiting room with a traffic light tool that we've developed to capture what matters to the family that day, so that we can cover a lot of things quickly and then really home in on what matters most to the family. We think about the child or young person's epilepsy, their constipation, their sleep problems, their postural management, their hand function, their equipment needs, issues at home, school, access to leisure and activities. We plan any interventions together rather than in silos as occurred before. And there's plenty of opportunity for questions and discussion, and there's always cake. The outcomes of interventions and the views of the children and families are captured and documented in subsequent consultations. Young people approaching adulthood are introduced to the neurorehabilitation consultant in regular transition clinics. So there's a robust handing on of the baton of the leadership of multidisciplinary care. We know that the care that we provide for all children with cerebral palsies in our area are equal, regardless of postcode, because we've got the data to prove it. We know we've eradicated hip dislocations in children with cerebral palsies that come through this service. Again, we've got the data to evidence this. We manage most things in-house, but of course we liaise with other experts as we need to in other centres. But families do value local care with the hands-on team working together. We serve a total population of around 350,000 people. We run these joint clinics twice a month, and we see up to 10 children in each clinic. We didn't have any extra resources to get this up and running, but I know that other areas will struggle with not having the people with the right expertise. When we set up paediatric disability as a subspecialty of paediatrics, we aspired to have a fully trained paediatric disability expert for every 100,000 population. We're not there yet, we've a long way to go, so that's for the shopping list of asks, please. We also need sufficient therapy expertise and sufficient paediatric orthopaedic expertise. But most of all, we need to work together with the child and the family as the focus and the lead for everything that we do, with their goals. We need to find out about their goals and then action them. Thank you very much for listening.
Thank you for that. That does just show what good can look like. And I'm going to, before I go over to Dr. Helen Hunt, I would just like to say I've noticed people putting questions and chatting in the chat. That'd be really useful if you continue to do that, just in case we run out of time at the end for questions. So chat away in the chat group. Dr. Helen Hunt is a trustee of Action Cerebral Palsy, and she's the parent of Wilf, who has cerebral palsy, and she's going to talk to us about her family's story. So straight over to you then, Helen. You're very welcome. And you need to unmute yourself, Helen. Oh, there you are.
Yeah, just realised that. Thank you. Okay, hello, my name is Helen and I'm Wilf's mum. Wilf is 6.5 years old. He's got quadriplegic cerebral palsy, is globally delayed, and while often very vocal, he is non-verbal at the moment. Will came into this world ticking many of the risk factor boxes for CP. My waters broke at 25 weeks and he arrived at 28. He had chorioamnionitis, neonatal sepsis and bacterial meningitis. He was plugged into the system from the start and placed on a pathway of regular review and follow-up with both a paediatrician and a physiotherapist at our local hospital. Despite that, he was not diagnosed until he was 16 months old, and he still fell foul to this watch and wait mentality. Around then, a review of the brain MRI he had at 4 or 5 months old, which we were told at the time was normal, in fact showed moderate to severe white matter damage. Until that point, we had been operating on the assumption Wilf at the age of 4 months had a normal looking brain on MRI. Despite being high risk for CP, the physiotherapy input Wilf received was generic in its approach and lacked intensity. It was certainly not adequate in taking advantage of these goals years in terms of neuroplasticity. Wilf was 5 years old before we discovered a school for parents in the neighbouring county. We would have jumped at the chance to go there, but at 5 years old, we were too late. School for parents is probably very similar to what Lindsay was talking about earlier about the early intervention service offered at Pace. My son, and many like him who are not coincidentally close to a centre of excellence, are at the mercy of the services provided by his local child development centre. There is huge disparity in the quality of those services, as we have seen in the Variations in Care report by Action CP earlier this year. Wilf has not only been a loser somewhat in the healthcare postcode lottery, but in the education one as well. As a result, every Monday morning, we wake up at 5 AM, load the car with all of Wilf's equipment, pretty much got everything Bert had said that he had on his list, and we have a 120-mile school run. Wilf's home in the week with either myself or his dad is a caravan on a campsite. Not a nice big static mobile home type caravan, but one you attach to the back of your car, 8 foot wide, 22 foot long, where I have to top up our water every day and manually empty our toilet. We stay here until it's time to drive the 120 miles back home on Friday afternoon. Supporting a severely disabled 6-year-old and meeting all his needs from mobility to toileting, from washing to feeding in a caravan is quite a task. But staying in a caravan is the only way we can afford to send him to the closest school to us that can give him the education that is adequate for his needs that have most likely been exacerbated because of the lack of good, effective early intervention. Without this school place, 2 counties away, Wilf would be at our local special needs school without a robust CP-specific curriculum, with no peer group he can relate to in his classroom, and without programmes of learning and therapy intensive and repetitive enough for him to learn. At the same time, he would be reliant upon physiotherapy and OT input based on resource rather than need. Wilf was offered a once half-termly review by our physios, and that is simply not enough for a child with severe cerebral palsy. Because the physio and OT provision is so inadequate and inconsistent, failure to meet basic targets becomes inevitable, and so begins a destructive feedback loop whereby expectations get lowered even further and children are not deemed ready for particular activities and tasks. Wilf's lack of progress under such a regime informed our decision to move schools. We travel so Wilf can attend a specialist school for the education and development of children with CP. Our experience has taught us that time is of the essence. Unfortunately, we lost out to some degree on the golden years of neuroplasticity up to the age of 2, and Wilf is now playing catch up. So when I talk of centres of excellence, as a parent, I combine health and education in that, because these children's therapeutic needs and educational needs are one and the same. Wilf now attends Ingfield Manor School in West Sussex. Wilf School is a perfect example of a single centre of excellence that combines both health and education according to the pupil's needs. When I say health, I mean sort of from a therapy perspective. They have a transdisciplinary team of on-site physios, OTs, speech and language therapists and nurses who respond promptly and creatively to Wilf's changing development and superbly meet his combined education and therapy needs. They do not separate education from therapy in the way many other schools do. Instead, his therapy is incorporated seamlessly throughout his individualised curriculum and his school day. When Wilf arrived at his new school in September 2019, he had made no progress for more than a year and had even gone backwards in some areas. 15 months later, and despite missing roughly a term's worth of school due to COVID, he is not only sidestepping again, but also stepping forwards with a ladder back and through parallel bars, is sidestepping upstairs. He eats all his school dinners, sometimes more than one portion. He can eat independently with a spoon or a fork, and he is learning to use the toilet. He is paying attention to his teachers, mark making, engaging and focusing so much better on tasks at hand, and his communication is really coming on. When a CP child's needs are not met, I would liken it to locked-in syndrome. It may sound severe, but I really feel this. For Wilf, the right combination of therapy and education has given him a voice and unlocked his potential. It is with that in mind that this tired, worn-out mum, who has exponentially aged in the last few years, would like to hand you her policy wish list beyond a regular decent night's sleep. All professionals and policymakers spend a day in the life of a child with CP who is not adequately catered for therapeutically or educationally, so they get to experience everything they go through. Perhaps this will bring to life in their minds my analogy of locked-in syndrome for these children and give policymakers a sense of urgency. The clock is very much ticking for these children. Following on from that, I would like policymakers and purse string holders to spend a day in the life of a parent carer for obvious reasons. Guidelines need to be more ambitious. Why not a 2-week wait referral to a child development centre and ambitious timeframes of when they can be seen at a centre of excellence? Referral to centres of excellence should be treated as standard. clear definitions on what adequate means for early years education. Without this focus, we run the risk of educational establishments becoming glorified babysitting and childcare services. These children really need to progress. Proper auditing processes to assess whether services actually work. Are they fit for purpose? How do you know whether your local children's therapy team are enabling CP children to progress? How do you know whether the local child development centre is referring who they need to refer on to a centre of excellence? How do you know GPs are even referring into child development centres? But really, all that we're asking for in this particular APPG is a standardised pathway of care and national centres of excellence that parents can rely on to provide the expertise and specialism required for children with CP. It's not really a lot to ask. I say that as a parent, but here in the UK, we have amazing professionals, but we haven't had the will politically to prioritise this. Thank you.
Yeah, thanks for sharing that with us, and very powerful. And I know when I first heard you tell that story, that's probably when I cried for the whole meeting, I think I remember. And yeah, I'm so pleased that Wilf is thriving, but it's frankly disgraceful that the lengths that your family have to go to in order to receive that service. So thank you again for that. Next we have Dr. Henriette Van Ryten, probably said that wrong as well, I apologise, who's consultant. Perfect. Oh, was it? Good. Consultant in pediatric neurology and neuromuscular disorders. Oh, you have a brilliant name and title there to read out. So straight over to Henriette. Very welcome.
Thank you very much, and thank you so much for giving a chance to give my thoughts on this subject as well. And obviously I come from a slightly different background with my interest in neuromuscular diseases, but as you'll see from this talk today, or my 5 minutes, a lot of the issues we face in our field of medicine are very similar to the issues in cerebral palsy. I strongly believe that if we're going to develop new pathways of care, improving a diagnosis is a very important first step. And vital to that is assessment of motor skills in children. So on the left is a child with normal motor development, and motor development, as a lot of you will know, is supposed to be a lovely progress where you progress from head control to developing rolling to developing sitting, and that child on the left is doing all of that. But sometimes something goes wrong in the development of motor skills, and an abnormal motor skill will appear, which is what you can see in the picture on the right. A very floppy child who handles like a ragdoll, and this child, that is actually me holding the child, was 6 months old before I first saw that child, before that child was referred to me. Now that late presentation has significantly affected his outcome, his treatments, and my next 3 or 4 minutes is going to be about why that has happened and how can we change to address that. So if we talk about abnormal motor skills are actually the first sign of a lot of different childhood conditions, not just neurological, not neuromuscular, but also childhood arthritis, oncology problems, orthopedic problems, all present with atypical or abnormal motor skills. Now, how are we going to detect these? These are detected in primary care, and I think it's sometimes underestimated how important the role is of primary care in this. They are the ones who have to refer the children to us as tertiary or secondary specialists. So we need to equip them with the skills to be able to detect our patients. Now in my field, in neuromuscular diseases, we are dealing with a problem of a significant delay in diagnosis. And actually, the age of diagnosis has not changed in the last 40 years, which is incredible. Particularly when you think that these are progressive conditions, that every day these children wait for a diagnosis, their muscles deteriorate. And a delay in diagnosis means they have a delay in access to care, and this means access to the right physiotherapy, access to screening for respiratory conditions or cardiovascular conditions, but also a delay in access to treatments. Now, for a lot of these conditions, and also neuromuscular conditions, we now have life-changing treatments. It's a huge industry we're talking about new treatments, gene therapy, at a cost of approximately £2 million for one patient. But I strongly believe that if we do not improve the age of the diagnosis or the timing of giving this treatment, these treatments don't work nowhere near as well. So it's affecting the outcome. It's affecting the outcome not just of that particular child, but also the outcome of siblings. Because of a lot of the conditions I deal with are genetic conditions, which means that if we have a delayed diagnosis in a child, this will also affect the chance of future siblings born with similar conditions. Next slide, please. So if we look at how the assessment of motor skills in children is done, this vital skill, which is occurring in primary care, this is all laid out in the Healthy Child Programme, which is basically an overview of all the child health checks done in the first 5 years of life of the children. Next slide, please. So how is it done? So it's mainly done by health visitors and GPs. And there are 3 most important reviews, which happen at the age of 6 weeks, 9 to 12 months, and 2 to 2.5 years. Now, these are very broad assessments, but they also all include a motor skill assessment. But that's only a very small component of the overall assessment. Next slide, please. What's going wrong? Now, obviously, these are my views, but I've spent a lot of time looking at this, and there's a few things I've picked out. The first one is that the motor skill assessment, which is done at these checks, is very variable. It depends on which region you live in, which country, Scotland or England, you live in, or Wales, but also when the assessment is done. The 6-week assessment is mainly done by GPs, and it involves a proper motor skill assessment. Unfortunately, a lot of the motor development assessment afterwards include only a questionnaire to assess motor development. There is no hands-on assessment. And I think that causes children with abnormal motor skill to fall through the net, basically. Also, what has happened recently in the last few years, we've stopped with the preschool check, which was a vital check. And this has led to, in my clinic, in my neuromuscular clinic, I now get referrals from teachers, which I think is absolutely unacceptable. But teachers know what normal motor development is, so they will stop their child who struggles to walk or falls over. And I think also, if we are expecting the primary healthcare professionals to send us the children with abnormal motor skills, we need to have a look at how we train them. And actually, I've spent time looking at how they are trained. Health visitors have very limited training in the assessment of motor development in children. GPs, who also do the assessment, you can actually train or become a GP without any training in pediatrics. So how can we expect primary healthcare professionals to pick up abnormal motor skills in children if we do not train them? In addition to that, there's a huge pressure on primary care, as we all know. So they have such an important task for us as secondary or tertiary clinicians. We want to treat these children early, but if we don't equip them with the right skills to identify the patients, we cannot treat them on time. Finally, I also think the referral pathways are unclear. If a GP or a health visitor is presented with a child with atypical motor development, who do they refer to? Is it a community pediatrician? Is it a neurologist? Is it a general pediatrician? It is unclear. And again, we have to think about that. Next slide, please. So in my opinion, current practice is failing children, and not just children with a neurological diagnosis such as cerebral palsy or a neuromuscular problem. Late diagnosis affecting children with abnormal motor skills is also affecting children with arthritis and children with orthopedic conditions such as developmental dysplasia of the hip. Next slide, please. So moving forward, it is my very strong opinion that no matter how good a treatment or a care pathway is, late diagnosis is a major determinant of outcome. And I feel very strongly that if we're going to develop new pathways, we should include primary care, because they are the ones who are bringing us the patients. So they need to have the right skills to be able to identify those children. For that, we need to improve training in assessment of motor skills in children. So I've done already a bit of work on that for primary healthcare professionals. I've written an e-learning module for health visitors and GP just to help them recognize when a motor development skill might not be quite normal and what to do with that. I strongly feel that we cannot assess motor development by using a questionnaire, by asking parents to rate their child's motor skills. We need to go back to a hands-on motor skill assessment in primary care. Very important. We also need to improve referral pathways to secondary care. It needs to be clear that if there's a child with abnormal motor development, what does the GP or health visitor do with that child? Who does that child need to see? And finally, and perhaps this is a bit controversial, but I think we should involve parents in this as well. Because at the end of the day, the expert on their child's motor development is the parents. They are with their child day in, day out, and they know when something is not quite right. And they should have the skills and the knowledge to know what to do with that. And we know that all children in the UK carry a red book with them. And I think we should try and work on maybe adding some red flags for motor development in there, or putting more information in there to empower the parents to say, hang on a minute, my child is not developing quite properly. Can we do something about it, or can you have a look at that? So these are my suggestions, which I hope will help with your cause as well. And I'm very grateful for you giving me the time to raise my concerns on this issue. And I hope together we can change this practice. And I'm very happy to answer any questions.
Oh, thank you for that, Henrietta. That is, it's presentations like yours, facts like that should be making us very angry. Really very angry that, you know, though that late diagnosis determines the outcome and the quality of life for a child for the rest of their life. It's
the most basic thing. We need to find the children first before we can treat them. And I think that's where we need to put more energy, not more energy in finding more expensive treatments, gene therapy. We need to find the children first.
Yes. And my daughter was nearly a year before she was diagnosed. So who knows what the outcomes may have been for her if only she'd been diagnosed earlier. Okay, thank you again for that. And we've got now Dr. Yasmin Dialwis and Dr. Anita Devlin from the Great North Children's Hospital. So I'll hand straight over to you to talk about how levelling up standards of care.
Hello, I'm Anita Devlin. I'm a paediatric neurologist in Newcastle, and I just wanted to say a couple of points following on from day one, which I listened to with interest, and I wanted to kind of join it in to what I'm about to say. Amanda used postcode lottery on day one. Bert said that he was fortuitous in his circumstances, and Alison, the OT, was lucky with her circumstance because she knew how to access the system. And it's certainly true that what we're aiming for in terms of regional hub and spoke models of care and regional and national standards and pathways is the right way to go about abolishing these inequalities of access. Access, assessment and intervention. It's at all three levels. The systems fail. We have a good example though. We have the CPIP system, which has now been introduced in England and funded by NHS England. And I'm a member of the NHS England CRG, of which Charlie Fairhurst is chair, and he spoke on day one, which managed to secure funding for the CPIP system. I don't need that slide yet, thanks. And it can be done. The only thing is the timescale. So Sweden started using this in '94, Denmark in 2010, Iceland 2012, and it was 2019. And that's a highly evidence-based, highly effective intervention, and things just take too long to actually implement. In terms of research, I just wanted to make the point, and I think it builds on what Henrietta was saying, which is, you know, we shouldn't need to justify why we need to identify this condition early. I can't think of another condition that we still talk about where we're trying to justify why we're finding it early. All conditions need to be identified early, because on that basis you then build on comparisons of interventions and how you can alter outcomes. So I really think whilst research is important, we should almost bat back the need for any further research on why we need to identify these patients. I'd say it was fairly obvious. In terms of the, there's a huge education gap, which came up with Alison on day one about primary health care and health visiting, and the skills in terms of recognition of normal profiles of motor development. Too often, I hear parents in clinic come to me saying, I have been telling the health visitor and GP that something is wrong, and I have been repeatedly reassured or indeed told that I'm an over-anxious parent and everything is fine. The knowledge and the tools are lacking, and I agree with Henrietta that that's where some work needs to go in. And I was also surprised when Alison said that speaking on behalf of health visiting, that they were going to do a review and maybe implement an assessment at 3 to 4 months. But gross motor development wasn't going to feature as a part of that assessment. Now, at the moment, I don't think it would be worth it, because if people aren't recognising it at 6 months, I really don't think they're going to recognise it at 3 to 4 months. But it's just an indication, I think, that these things are not on the radar, and they need to be, more so than they are. The final thing I wanted to mention was Simon Kenny, when he spoke, mentioned operational delivery networks, these formal structures in which commissioners and patients work together to optimise healthcare, which were launched. He drew a link to PICU for us because that's the kind of closest he could get. And the reason for that is that paediatric neurosciences operational delivery networks were not supported beyond 2019. We had them, they worked, we had evidence that they worked as clinical networks. They are no longer supported. And certainly Charlie, and with the CRG behind him, is trying to make a case to reinstate those networks, because it is through those clinical networks that we can actually implement some of the pathways that we're talking about. So next slide, please. Hello. Next slide, please. So that's a map of the Northeast population. No, go back one that we care for. And I'm not going to read it all out to you, but it's suffice to say the geographical area is quite large. Each sub-area of that has a number of foundation trusts and a number of CCGs. And the centre, the neurosciences centre for this area is Newcastle. So you can see that it is quite a big area with quite a number of different CCGs and referral hospitals. Next slide, please. The purpose of this slide is not to introduce you to everybody on the slide, you'll be pleased to know, but it's just to really illustrate that at a hub, a regional hub such as Newcastle, call it a centre of excellence if you will, but this is the number of people who have to work together. These are all paediatric specialists in their own field. So you've got neurologists, you've got geneticists, physiotherapists, OTs, gait lab, orthopedics, plastics, neurosurgery, opticians, orthoptists, dietitians, ophthalmologists, nurse specialists, and I haven't even got everybody on there. But in order to be a hub that can really focus on specialist assessment, you need all of these people, and it's quite clear that all of these people can't be provided at the level of a DGH, a district general hospital, because that's not going to work. Next slide, please. So this was just a flow chart of how it seems to work. You have primary care, health visiting, and parents and carers at the top. So that's the primary level. And then the referral is made to most usually, and here I'm talking about children who are not children that Lindsay was talking about, the family that Lindsay was talking about, where they weren't automatically put in a surveillance program as a high-risk child. So they have a risk of falling through the net. Most commonly, those children are then referred to a community paediatrician, and the myriad of services you can see at that secondary level, but it's crucial that the children have access to, and that is coordinated best in the child's locality, close to home. And different areas vary in how these systems work, so it's very important that they have a local professional leading on the holistic care from that point of view.
all of the people I've just shown you fit in the green box at the bottom, which is specialist assessment, investigation and intervention. And what it's important to have there is that they enter specialist services without waiting excessively as needed, but then return to the services close to home for provision of the rest of their needs. I'm just going to hand over to Yasmin now.
Hello, I'm Yasmin Dialvis, a neurodisability consultant. So next slide, please. So we run a variety of clinics at our tertiary neurodisability service. We do not have all the services we would like to have. We are still in negotiation. For instance, you cannot see psychology or sleeping service, sleep disorder service as such, but we are quite proud of what we have at the moment. So to illustrate how one of our services work in a hub and spoke model, if you go to the next slide, please. I'll take the posture and movement service. Again, this is a transdisciplinary service where we have the support of the occupational therapist, the physiotherapist, if necessary, a nurse specialist. And we clearly depend a lot on the local team to provide the background and the support network for the child. We expect that the child would have been identified and given the support network from a local CDC team or a similar service with a multidisciplinary professional team there, along with an occupational therapist, maybe an orthotist, a physiotherapist. And at that point, a problem would have been identified after their assessment, and the referral would come to our tertiary center. When it comes, before referral comes, we ask for opinions and their opinion about the child, and then we will undertake our own assessment, but we will continue to talk to and communicate with the local team, because we undoubtedly need their support in taking forward management plans. So in the slide, there are a variety of management options we would offer, but like I said, we would be continuing to communicate within the services to achieve best outcomes for the child and the family. I won't dwell too much on it. Next slide, please. As everyone said, there are huge challenges, even for a tertiary center like us. This service has been built up by over the years. Jill has been one of our previous colleagues who have built up a lot of this communication, but there is still a lack of capacity at all levels. At the level of a tertiary neurodisability service, we lack number of hours that each orthotist or AHP can spend for consultant levels, but particularly I think occupational therapy is probably the most affected. That is not all. There is lack of capacity at local levels. That is very evident from what everyone spoke today. And in terms of what would this mean is also the impact it has on developing national hubs. So the lack of specialist neurodisability pediatricians, as Karen suggested, the 1 per 100,000 is not achievable because we do not have them as yet. Changing organizational structures, we, I think, heard a lot about it. Difficult to find who is responsible for what. This is a time and time again problem. And I think I'm hugely aware of the problems coming up with transitioning of these young people into the adult world. And there is a lack of support for adults with cerebral palsy, and there are huge issues in there. And I think whatever the pathways that we make from this APPG must look into a lifespan pathway and a support for the adult with CP as well. The only other thing I would like to mention today is that our increasing survival of very extreme preterm babies, which would no doubt impact on the number of children surviving to have CP, as well as complex and severe disability. So I think that should be taken into consideration as well. And I will stop now. Thank you very much for this opportunity.
Oh, thank you both for that. That's wonderful work that you're doing up in the northeast. That should be hopefully replicated across the country. Can I just now hand over to Amanda Richardson, who's the Chief Exec of Action Cerebral Palsy. Amanda's just going to sum up and give us some thoughts, and then we do have there are still 33 people on this call, I think. So we've got a few minutes if people want to stay for some, if we have a burning desire to ask some questions. But I'll just hand over to Amanda first.
Well, thank you, everyone. And I'm really not going to say very much at this point because well, I know we're sort of having a little bit of an ongoing chat in our questions, and I'm sure those will continue beyond the session as well. But I would just like to say, you know, it has been an absolute privilege to hear from the most extraordinary people doing the most extraordinary work, families, parents, professionals, and through both of these APPG sessions. And, you know, I cannot thank you all enough for taking part in this. This has been, I think, a really huge push in the right direction. And I suppose really all I would like to say is that, you know, we know there is a long way to go and a lot to achieve, you know, if I dare say it, to achieve a level playing field from where we are at the moment. But I think it is abundantly clear that there is huge skill, huge desire, huge will, talent and passion amongst the professionals, the workforce, families and our supporters to get things right for the most vulnerable of our children and their families. It has to be, as we've all spoken about today, it has to be about the child within the family, within the nurturing environment of their family, and that is a unit to be cared for. So that those children can go on and lead the best lives they possibly can. And we've heard about those problems today, but we've also heard about some solutions. And I think that is very encouraging. And it does put us on, I think, a positive pathway ourselves to being able to really put together some lasting and sustainable progress for the future. So we do look forward to working together and to really use what we have learnt. You've put a lot of time and effort into this, and I think it is really beholden to us all to use what we've learnt today and in the first session to make some real changes. And can I just finish by saying, please, it's not too late to submit written evidence for this APPG as well. And, you know, with your permission, we would like to use any of the slides today that have been used, but also please encourage your networks to submit written evidence along the terms of reference for these two APPG sessions. We'll be pulling it all together, and I know that the APPG will do their very best to help us move forward. So thank you very much, everybody.
Thank you. Thanks for that, Amanda. And before we do go, then, does anybody have a question that they'd like to ask? If you don't have a one now, we're saving the chat, and if you have some questions in the chat, then that will be saved and the relevant people can get back to you.
If it's okay, Mary, I just wanted to pull out a couple of questions that came up.
Okay then, yeah.
One that was from Ben. So this was sort of answered in the chat, but it'd be great to just pull that discussion out. So to Jill, you mentioned the reallocation of resource due to other conditions, including ASD, and just wondered if you could expand on the impact ASD services are having on support for other conditions, including CP. Ben explained that as a pan-disability charity, his organisation is interested in how our services can support blockages or strains on statutory services. So Jill, if you don't mind just stepping in to answer that.
Hi, yeah, thank you. Yeah, I think it's reflected across the UK in the BACD meetings where we have representation from all regions of community paediatricians, that there's a massive pull at the moment on neurodevelopmental assessment for children with autistic spectrum disorders and ADHD, and that is absolutely needed. It's not that we want to sort of deny anybody else of any services, but those community paediatricians are not given any extra resource, nor are their therapists. So actually it's natural then that children who may or may not be under some more medical consultants at different hospitals, like children with CP who may have a paediatrician who's looking after their epilepsy, or may still be under neonatal follow-up, or still be in a tertiary centre, then don't get as much resource from the community paed centre. And just as Anita Devlin's talk said about that, and Karen Horridge was saying about how the care needs to be at the child's locality with a community paediatrician at the centre, or community paediatric service at the centre. It might be the therapist rather than the paediatrician that needs to be the key here. But the point is that there is increased demand, no increased resource, and therefore people get pulled in different directions. Now, I am not an expert on ASD and neurodevelopmental disorders. I know through BACD we do have data on the increased referrals on over the last 5 to 10 years for that, and therefore we can. Sorry, Bert, are you
this body of work?
Yeah, but I can put anybody who's interested into touch with the more sort of neurodevelopmental leads within BACD and the piece of work that has been done on the increased referrals and what's happened on the resources through BACD. So I'll just share my email with everybody in the chat. I'd already done so with Ben, and then people can get in touch with me through BA from that point of view.
Thank you. Was there any other questions? Did Bert have a
Yeah, so there was one more question from Bert, which was, what action points do we think should be considered in the immediate term, given the difficulties geographically and the disparity of services? So if any of the panelists had any thoughts on that one, do come in.
Karen Horridge here, just to reiterate the need for robust population data. If we had data about the needs of all children everywhere in all settings, then their needs would be visible, and needs that are visible are more likely to be met. If the needs aren't made visible, we can't compete with grown-up services, with everything else that has to be funded, and at the moment the needs of disabled children are very much hidden and not articulated with those who commission services.
Okay, well, if everybody's finished asking questions and any other comments, then it leaves it to me to just close the meeting, and thanks to all of the speakers. If I only had that knowledge 30 years ago, even a tiny bit of that knowledge 30 years ago, would have been a great help. It's been absolutely fantastic. And thank you to Amanda and everybody at Action Cerebral Palsy for pulling this group together. It's been 2 amazing meetings, and I know that there will be that report coming out in January. And hopefully this is the beginning of seeing some real change for families and children with cerebral palsy. So thank you again, and have a lovely Christmas and New Year, and hopefully we see many of you again in the new year. Okay, thank you.
And thank you.
Thank you. Bye.
Bye. Thanks. Bye. Bye.